All right, glad to have you back. It's still Good Morning Nigeria live on the network service of the NTA. And just before we get into the conversation for today, which borders on the 2025 to 2028 malaria elimination strategy, let's quickly take a look at this background report put together by our correspondent Ibrahim Bello Gunda.
Nigeria accounts for 27% of global malaria cases and 12% of malaria deaths, losing about $1.1 billion annually to treatment, prevention, and lost productivity. The federal government and Malaria Consortium have unveiled a 4-year strategy to make Nigeria malaria-free. The renewed resolve was announced in Abuja during the unveiling of Malaria Consortium Nigeria strategy, where government officials and development partners emphasized sustainable, local-driven interventions and deeper integration of malaria control into the broader health system. Both parties reaffirmed their commitment to eliminate malaria in the country, pledging stronger collaboration under sector-wide framework focused on prevention, elimination, and eventual eradication of the disease. The government is placing greater emphasis on ownership, sustainability, and integration, not only in coordination, but also in service delivery under the Nigeria Health Sector Renewed Initiative by aiming not only for elimination, but for total eradication, as stakeholders look forward to the day the World Health Organization will certify Nigeria malaria-free. How does the new strategy differ from previous malaria control programs in Nigeria? Why is Nigeria considered a critical country in the global fight against malaria, and what key factors have slowed malaria elimination effort in Nigeria in the past? This and more will be our focus on Good Morning Nigeria as we discuss 2025 to 2028 malaria elimination strategy.
All right, thank you very much, Ibrahim Bello Gunda, for that background report. Now let's begin this conversation, but first introduce our guests right here in the studio. And I'd like to start with Dr. Chibuzo Gwoma, who is the Program Director, Malaria Consortium. A pleasure to have you on Good Morning Nigeria.
Thank you very much.
All right, let me also welcome here in the studio Dr. Jennifer Chukwumerije, Technical Specialist, Malaria Consortium. Thank you for coming.
Thank you very much for having me.
Yeah, right.
All right, also part of the conversation, joining us right here in the studio is Dr. Olatayo Abikoye, Country Program Director, Malaria Consortium.
Thanks so much. Good morning. Thanks for having us.
All right, and also here with us is Dr. Ahmed Sani Bala, Department of Family Medicine at the Federal Medical Center, Abuja, and CEO of Vital and Medical Foundation. Pleasure to have you again, Doctor.
Thank you for having me.
Welcome.
All right, let's begin with Dr. Olatayo Abikoye, who is Country Program Director at Malaria Consortium. Tell us about this 2025 to 2028 strategy. What measurable targets does it set? Okay, say for 2028, because that's terminal.
All right, so thanks so much. Just to set the tone very clear, it's a critical period for us as a country, the malaria program, generally in the country, because it comes at a point in time when the country itself, the National Malaria Program, is also at a strategic designing period for the next 5 years. So we have what we call the National Malaria Strategic Plan that is being finalized and it's going to be made public very soon. And that is being led by the Federal Ministry of Health through the coordinating body known as the National Malaria Elimination Program. But Malaria Consortium as an organization was established over 2 decades ago, one of the global leading international NGOs registered with UK Charity. We've been supporting the National Malaria Elimination Program over the years in the rollout of interventions, life-saving interventions as it relates to malaria prevention, control, and of course our joint vision towards the malaria-free Nigeria. So as an organization recently, we launched what we call our own organizational strategy known as the Malaria Consortium Strategy. It's a 3-year strategy feeding into a bigger strategy, of course, trying to support the national malaria program, the National Malaria Strategy Plan. So it feeds into that National Malaria Strategy Plan, and it's a 3-year strategy. And of course, we made it 3-year because we see that the landscape is evolving rapidly. Recently, we can all attest to COVID-19 that we didn't expect. So we wanted to have a short strategy so that within those 3 years, as things changes within the landscape, we can respond accordingly to the changes within the landscape, evolution within the landscape. And as part of that strategy, the strategy has 5 pillars. One of the pillars speaks to research. We want everything that we'll be doing to be evidence-driven, data-driven, and of course that feeds into another strategic pillar of this strategy that speaks to policy and practice. So the results of our researches, the data that we are generating, can translate into policy shift, and of course into practice, and of course into implementation. And of course, one critical pillar of this new strategy also speaks to partnership. We intend to engage with stakeholders across board, from the national, the state, even to the local government, the beneficiaries, and the communities that we serve. So partnership is another strategic pillar within this new strategy that we intend to focus on strongly for us to be able to achieve tangible, sustainable, and scalable health impacts within the malaria space within Nigeria and, of course, other countries where we work.
Fantastic, Dr. Bikoye. But I'd like to remain with you. What makes this strategy different from other strategies? I mean, there have been so many plans in the past that didn't quite hit the target. So what makes this different, and what does elimination mean, realistically, for a country, Nigeria, that has the highest burden of malaria globally?
So, like you rightly said, Nigeria still carries the largest burden of malaria globally. And like I mentioned earlier on, one of the strategic pillars of this new strategy speaks to research. We want to be generating evidence, data that we can quickly respond to, programs can adopt and adapt to within the shortest possible time. We are trying to create an environment that is resilient, health system that is resilient, that is responsive, and of course community-led, locally driven drive for our implementation. We can now attach to the dwindling resources within the space where we work. So we want to adapt local solutions to our problem. We want to see malaria as a problem, as a country, as a people. We want to own the program, we want to own the intervention, we want to own the rollout of solutions that are sustainable, that are scalable, and that are impactful, ensuring that every dollar can be maximized. The efficiency of our interventions needs to be upskilled. The effectiveness of our interventions needs to be upskilled. And of course, we need data, we need evidence to develop all of this. So this is different. It's coming at a critical period where things are changing rapidly within the landscape. And of course, resources are dropping, reducing. So we need to be able to demonstrate that every dollar that is being used impactfully, is being used more efficiently, and of course to get the desired result that is impactful to the people of Nigeria and the space where we work.
Okay. Thank you, Dr. Bikoye. Let's give you a little break and let me get to Dr. Chukwumerije. Now, prevention is considered, the most effective weapon against malaria. So what specific preventive interventions are prioritized in this new strategy?
Okay, thank you very much for your question. I'm going to leverage a little bit on what my colleague has been speaking about. As you very clearly said, malaria is the control of malaria cannot be removed from prevention. And the National Malaria Elimination Program has spearheaded a number of effective tools that have targeted malaria prevention, amongst them of which are the use of insecticide-treated nets, seasonal malaria chemo prevention, of which our organization, Malaria Consortium, pioneered about 2013, 2014. We also have larval source management, the use of residual insecticides for the environment. So there is a lot that is being done, and this is very key because we recognize that for us to reach the long-term goal of malaria elimination in this country, we have to actually prioritize prevention. We have to ensure that we are investing in preventive mechanisms, interventions, and tools. We know the saying that prevention is better than cure. I would also add to that myself and say prevention is cheaper than cure, because one thing prevention does is that it breaks that transmission barrier. So before you actually have to start dealing with children coming down with fever and clinical cases of malaria, you've actually stopped it at the point of transmission. So it is something that our strategy really focuses on. As Dr. Tayo mentioned, one of our strategic pillars is focusing on research. It's also focusing on implementation, and we want to be able to implement a lot of these preventive strategies that we are rolling out in a way that is, as he said, locally led and also relevant to the national priorities that are outlined in the National Malaria Strategic Program.
All right, thank you, Dr. Chukwumeriju. Dr. Ogwama, I'd like to get to you. Dr. Biko, you spoke and you said a health system that is resilient. Dr. Chukwumeriju says prevention, working on prevention and all of that. Of course, when you say a health system that is resilient, I want to ask if that is possible when we do not have primary healthcare centers in every ward, in almost every community, when it is inaccessible, or even when it is present, medicines, basic tools are not available. So I don't know, maybe you speak more on that resilient health system. But you know, when she talks about prevention, I'm thinking, how do you want to do prevention when we still have floods in some communities, when we still have a lot of environmental issues, right, which of course contributing to the breeding of the parasite itself and eventually leading to malaria. But speak to us, this strategy, do you see it working?
Yes, thank you very much. If you look at the National Malaria Elimination Program guidelines, there are specific interventions suited for Nigeria listed and how we go about them. But the key issue is consistent use. For example, insecticide-treated nets have been proven to prevent mosquitoes from biting the person. But the key issue is consistent use, always sleeping under the mosquito nets. We'll find out that even though the coverage is higher, the consistent use rate is less. Again, the seasonal malaria chemo prevention, which is also prevention, is good in making sure that these children receive adequate doses of sulfadoxine pyrimethamine in the bodies plus amodiaquine to make sure that even when they get bitten by mosquitoes, it will not, mature into, it will not evolve into malaria. So mosquito can even bite a child that didn't sleep under the net, and then, but it will not move on to become full-blown malaria. So seasonal malaria chemo prevention, ITN use are key. Seasonal malaria chemo prevention is, supplementary, sort of is not the major. If we use nets first and use it to back it up, two of them can, even seasonal malaria chemo prevention alone has been proven to prevent up to 70% of malaria in children when they are properly used. So in Nigeria currently, 20 states and the Federal Capital Territory receive seasonal malaria chemo prevention, and the efficacy rate is quite high. And the last year, about 28 million children under 5 years of age were reached in these 20 states and the Federal Capital Territory. This year, more than 30 million will be reached. But Nigeria is wider. So it's just to consistently combine all these interventions. ITN use will continue to use social behavioral communication, health education, to tell people, please consistently sleep under your nets. People complain severally. If you use it for the whole 30 days and 29 days, miss the 30th and get bitten by mosquitoes, you're not safe. So you consistently use the nets. When you're supposed also to use the seasonal malaria chemo prevention, the medicines given to you, people give them directly observed therapy, their body, day 2 and day 3 doses. Parents should give them to their children or caregivers. You see, that consistency is the aspect we need to, NTA, other media, help us continue to, talk to caregivers, parents too. If we consistently, nets, SMC, seasonal malaria chemical prevention, they will prevent in this especially during the high transmission season. And then larval source management, indoor residual spraying, and other preventive measures, if they are consistently used, we'll be able to continue to, reduce the incidence of malaria. When you talk
about consistency in the use of the nets, are the nets free?
Yes, they are free.
Does it reach every community? Ooh. And what is the guarantee that there's replacement after a certain period of time? Because these nets tear. Yes. I mean, there's so many other things that could happen. So, yes. I mean, so speak about all these other issues, because you're talking about consistency. So somebody could have the net and use it for 3 months and something happens and there's no replacement. The person goes back to...
Yeah, we do our best. Also, handling of the nets are very important. If somebody takes these things very serious, it costs somebody money, even though you're receiving them free. If we, as the users, manage these nets better, they last longer. They've been proven
so
they can last.
Does it reach every community in Nigeria?
Unfortunately, no, because of gaps in funding currently. If you look at the requirements for malaria control, elimination activities for 2027 to 2029, there's a gap of about 6.6 billion.
So what's the plan?
Is to continue to move more, the donor dependency is quite high, and we know the challenges government and everyone is facing. But if we can go back to domestic financing, different aspects of domestic financing.
That brings me back to my question.
Yeah.
You said funding is low. Do you see this strategy working without funds?
Yes, in the sense that the onus lies on government and partners to look inwards, because the resources are there. Okay. It's just to try to
chime in here, Dr. Chibuzo. So, like I mentioned, you recall that I mentioned that one of the strategic pillars of this new strategy speaks to partnership.
Yes.
So we have, without ambiguity, those partners, those stakeholders that we need to engage with, their expectations, their roles, their responsibility, their levels of accountability. And these partners ranges from the federal, the state level, to the local government. We have a lot of things happening at the local government level. We have this autonomy that might come full-blown very soon. At the national level, and of course, nationally, we have things like Basic Care Provision Fund. We have the National Health Insurance Program. These are some of the things that innovatively we can engage with to unlock resources that we have within our system, rather than over-dependence on donors. And of course, like I mentioned again, that every dollar, every naira that is spent provides or gives us the most efficient impact. So research. So if you have 100 naira, for instance, how can we maximize the impact of 100 naira in the local government? How does research
give nets to every community in Nigeria?
Okay, very good question. So if we need to prioritize, for instance, we can look at data. Like I said, research, data, evidence. There are communities that have highest burden of malaria within Nigeria, even within states. There are local governments. It is what we call heterogeneity. One of the things that the new National Malaria Strategy Plan is speaking to is what we call subnational tailoring, where we can stratify the burden based on epidemiology, based on ecological patterns. So a state like Lagos State, for instance, they are close to elimination. The prevalence in Lagos is very low compared to some states in the northeast.
All parts of Lagos?
Yes. The commissioner even came out on air.
Yeah.
They went ahead to do what we call prevalence tests. That's the measure of the parasite level in the blood of people at a particular point in time. Lagos State has the lowest in the country currently.
Because if you go to Ikoyi, go to VI, go to Lekki, you are likely to get this result you're talking about.
Go to Makoko.
If you go to Makoko, Ajegule, Orile.
Yes, but when we're testing prevalence, we do it at a cross-sectional level. So you're not just restricting yourself to one socioeconomic group. You make sure that there's representativeness in the sampling that you do. And just to speak to what you were saying about efficiency, we can't do everything. And that brings us back to subnational tailoring. There are certain strategies that work based on the epidemiology and the contextual factors surrounding different areas. So for instance, Dr. Chibuzo was talking about seasonal malaria chemical prevention. That would be in areas with seasonal rainfall transmission. Yeah. We have other areas that have perennial rainfall transmission. Seasonal malaria chemical prevention is not adequate for that. But we have other. So I want to say this in a positive way. I do agree. I'll even be stronger than Dr. Chibuzo in saying that I believe that the goal of malaria elimination is quite possible, because we have proven tools that have been shown by research, as Dr. Tayo said, to be very effective. So what do we do when our available resources are limited? We prioritize. We make sure that we target what works in specific areas. And that is what the National Elimination Program and the Federal Ministry of Health as a whole is doing. We're all aware of the minister's sector-wide approach, and that leverages on unifying health sectors and making sure that we are integrating health programs to make sure that we maximize efficiency.
I like the approach that you're taking. Now you talk about the chemo prevention therapy. That's for children under what age?
Under the age of 5.
So what happens to children above that?
They have other, so here you have to understand the epidemiology of malaria as a whole. Malaria actually affects children under the age of 5 more because their immunity is not developed. So what we have found, what studies have shown us, is that by the time a child passes that borderline of 5 years old, they have developed sufficient immunity. Of course, they will still have periodic cases of malaria, but it's not as, I mean, I'm a mother, I'm not going to generalize, but most parents will tell you that their children that are under the age of 5 have more frequency of malaria. So that's why we are targeting that. And also knowing that when you target those that have the highest burden, what you end up seeing is the reduction in prevalence.
But it doesn't lead to elimination.
Of course, it's not, but it's not alone. As Dr. Chibuzo said, it's not standalone. So we are not just focusing on one thing. We also know that we have the malaria vaccine, which is an innovation that Nigeria also brought on board 2 years ago.
But just very few states have kicked that off.
It's a phased approach.
Let's give her a break.
No, it's fine.
Vaccines now, but the problem is the money to buy. Yeah, I was talking with MMV last week in Kampala. There's enough vaccine now, but it's to buy. Before, there were not enough vaccine, and we had enough money.
So now it's about funding.
Now it's about funding.
All right.
And then there are also other...
Nigeria has also scaled up.
Yeah, Nigeria has scaled up.
And we're moving to 4 states this year.
Out of 36?
We will move, it's progress.
All right, thank you. And thank you, Dr. Bala, for your patience too. Thank you for your patience. Now, from a frontline medical perspective, just how high is the malaria burden in Nigerian health facilities?
Okay, from the family physician's perspective and then the primary caregivers, we are the first port of contact with the patients. So Nigeria generally, we are in malaria endemic region. So sadly, the burden is still high globally. Nigeria, focusing on Nigeria and in Africa, Nigeria has among the highest global burden of malaria. So we see it across all ages, but as she rightly mentioned, there are some particular group of people that the burden it's much on, like the pregnant women and then the children, because they are still developing with low physiologic reserve. So we have very, very high prevalence of malaria up to that, even though there are interventions in place, but still the prevalence, the burden is still high, which is attributable to some factors that lead to this high burden that we have, ranging from improper diagnosis or lack of access to diagnosis in the first place to even know that the malaria is there, or the appropriate diagnosis. Then going forward after the diagnosis, the treatment, because most people don't do the appropriate treatment in terms of the combination of the drug, anti-malarial drug, because we have different combination of anti-malarials for different classes of malarials and all that. And then also the dosage. Some people will take anti-malarial drugs for 2 days. Once they feel the symptoms are resolving, they would abandon it. So these are some of the things that are complicating the issue.
What about misconceptions? For instance, what are the most common misconceptions still, prevalent in Nigeria?
Okay, the common misconception is that all fevers are malaria. So we can have fever from barrage of infective causes, from viral causes, from fungal causes, and other bacterial causes. So everything is malaria, and then they'll start popping up anti-malaria. And we have what is called drug resistance, which is among the things that are further compounding the issue of the malaria we are having, anti-malaria resistance. So this misconception of all fever malaria, without doing the appropriate and necessary basic investigation to confirm the diagnosis before getting an informed decision for the treatment. So this misconception about every fever is malaria, every body ache is malaria and all that. Yes, we are in malaria endemic region, but before commencing any treatment, ideally there should be a test to confirm the diagnosis before you proceed to...
Is it just drug resistance that is the challenge? Do we still have a challenge of fake drugs?
Yes, we have barrage of challenges. So drug resistance is one of the challenges, but we have other challenges, as I mentioned earlier. So we even have other challenges like low awareness. People are not even aware. There is a gap between the knowledge of malaria and then the general populace. Some people are not aware of how malaria is even transmitted, the factors within their environment. People, like in the rural areas, people are living with bushes around them, with stagnant water around them. They cannot correlate between all those lifestyle they are predisposed to and what and how it affects them and how it helps in breeding the malaria. So there is gap in there, and also there is unequal distribution of resources also in terms of accessibility to healthcare also in the rural settings. So that one also can affect and can lead to the increased prevalence of malaria. So we have different factors that lead to...
What about misdiagnosis?
Yes, there are misdiagnoses. There are misdiagnoses to contribute to that. But as I mentioned earlier on, basic malaria tests, we have a rapid diagnostic test, and then we have the microscopy. So if that is put in place, the healthcare giving, the health-seeking behavior is very good. So the misdiagnosis will be a minimal factor towards the contribution of the high burden of malaria.
All right, thank you. Now, Dr. Jennifer, just how important is early diagnosis and prompt treatment in reducing malaria mortality?
Thank you. That's a brilliant question. You've said it exactly. We have a phrase we use. We say test before you treat. And that is, as Dr. Bala rightly said, I really want to commend our colleagues that are at the front line, because these are the people championing the fight against malaria. But back to your question, as he mentioned, we have a culture that we have to fight in this country, and that is the culture of self-medication. As we have that, we also know that common phrase. Everybody says, oh, common malaria, common malaria. So you believe that every fever, every body ache, every chill, all those paroxysms that we have are malaria. But that is a misconception. We have a wide range of diseases that manifest as fever and with symptoms that are very similar to malaria. So what we do is to ensure that we test ourselves early. And let me say this, so it's not just testing, but early, making sure that as quickly as you feel the symptoms, you make sure that you get tested. As he mentioned, we have quality assured rapid diagnostic tests. These tests are available at patent medicine vendors, at chemists, at pharmacies. The National Malaria Elimination Program has, over the last decade, made a lot of efforts to make sure that these RDTs, as they are called in short, are readily available, and they are quite affordable, they are quite cheap. The gold standard remains microscopy, and this is available. We have malaria microbiology trained microbiologists in health facilities that carry out this microscopy. So what we have found is that if you get tested the right way, early enough, get that diagnosis of malaria, and get, as he mentioned, the right treatment, because that's another gap there. Utilizing the agreed upon malaria medications. We have first-line treatment, we have second-line treatment. There's a range of malaria symptomatology here. And we always think that it's just, we have uncomplicated malaria, we have severe malaria, and that's what ultimately leads to death. So what we want to do is, at least if you even have malaria, make sure we stop it at uncomplicated. And that's why once we get early diagnosis and get the right quality assured treatment, you were mentioning something very true, which is the fact that we still deal with falsified and substandard medications in Nigeria. And that is something I really have to commend the National Agency for Food and Drug Administration and Control. There have been a lot of measures that are being made in recent years to combat the issue of counterfeit medicines. But that is not enough. As Dr. Bala said, we also have to equip ourselves with knowledge. We also have to know what is right and what is going to save us, because ultimately the responsibility of your health is yours. The responsibility of your children's health is that of the parents. So you cannot, as they say, ignorance is not an excuse. You have to make sure you know what is right.
Thank you very much, Dr. Chukwumerije. I'd like to get to Dr. Abikoye now. you know, this initiative is a great one. Just some weeks ago, we're talking about malaria vaccines and all of that. And, you know, I'm like, well, so much effort given to dealing with malaria, but can we actually deal with it? She just talked about not getting tested before being treated, right? People just go to the counter and buy medicines, sometimes not deliberate, out of poverty, right? So can we actually deal with malaria if we don't deal with poverty?
There's this saying, general saying, that malaria is actually a disease of the poor. Those with inequities are usually the poor, those with limited access to healthcare, education, unfortunately hard to reach communities. They are most vulnerable. And one of the things that our strategy is trying to push for is to have health equities. Because you find out that those people that are poor, they have the highest incidence cases of malaria, the poor, the uneducated. So these are some of the things that we intend to look into. And of course, build, I'm going back to one of our strategic pillars, strategic partnership. So it's a multi-sector approach. It's not the Ministry of Health alone. We need people in agric, for instance. We need people in education. We need people in environments. We need to collaborate to drive this systemic change. So we need people in the Federal Ministry of Finance, for instance. If there are budgetary allocation for health, for malaria, how do we monitor the release and, of course, efficient use of such resources? So it's multi-sectorial. We need to drive strategic partnership. So, for instance, during our strategy launch as an organization, we brought in people from Ministry of Health, Budget and Planning. We brought in NAFDAC. So it has come to a point in time that we need every hand on deck for us to drive the vision that we so see of a malaria-free Nigeria. So it's beyond health, it's beyond the doctors, the frontline persons. We need everybody. We need the media. We need teachers in schools to pass the right messages. Then again, we need attitudinal change, behavioral change as a people. For instance, he mentioned places like Morocco, in Lagos. So there are some countries where they've attained elimination. That doesn't mean they don't have mosquitoes, but people need to be informed, okay? So before you can have malaria, you need to be bitten by a female Anopheles mosquito that has the parasite. So if there's no parasite in Mr. A to be transmitted to Mr. B, then the circle is broken. So it's not that there are no mosquitoes in those places, but they don't have the parasite within them. Again, the conception, like Dr. Bala mentioned, Dr. Jennifer mentioned, we tend to believe that every fever is just hotness of body, is malaria. That's the general perception of most Nigerians, that once you have fever, you have headache, you have malaria. Like you mentioned, a number of things can cause fever. So you need to be tested early, and you need to be treated according to the guideline for management of malaria in Nigeria, if tested positive for malaria. And if it's not malaria, we need to look for other causes of the fever and treat appropriatid.
All right, I would like our viewers to know they can be part of this conversation. The number is on the screen. You can send in SMS or WhatsApp messages. We would really love to hear from you. I'd like Dr. Ogoma to respond to this question. You know, I just asked him if we can deal with malaria, if we have not dealt with poverty. Then, of course, my next line of thought is if insurance is still very low, health insurance. I mean, people pay out of pocket. That's a big challenge for a lot of people. The medicines, I'm sure, that can treat malaria is about 4,000, 5,000. How many people can afford that, right? So, I mean, you want to do agbo, you want to do anything and all of that just to get your system working. But speak about what we can do to scale up insurance, just so that we can deal with basics like malaria.
Yeah, I know that health insurance is key. You know, there was a time, I think, some years ago, some states pioneered community health insurance and found them effective. We want to hope that government will become a little more consistent. It's not like a new person comes, a new set of, and that's where the media can also come in. But as Dr. Tayo mentioned, the partnership and looking inwards, domestic financing, the private sector, people that are well off in the country, people that have been blessed, people that have the resources, government, individuals, organizations, everybody coming together, communities, because communities can also even pioneer working with health insurance organizations, you know, health management organizations, and also, right, the good thing is even government has made it now is more or less mandatory for organizations that employ people to insure them, give them health insurance. So it's to try government to maybe move forward to the private sector, to the organized private sector, non-organized private sector. More information, bringing more people. Insurance, pulling the resources together will help us more. And then government can now, the good thing, even there are some states I know that give free, if it's malaria for women and children, it's free. It's just the health education. At times, some people are not even aware that these things exist. And then combining everything, partners, government, private, public-spirited individuals, everybody coming together, reaching out to tackle inequalities, inequity, dealing with some of those issues will help. And it's been helping.
All right, Dr. Guoma, thank you. But I just worry a bit because we are talking about governments, state governments need to be more consistent. And I'm asking, let me get it to Dr. Bala now. You are in the field. What is your assessment of this strategy itself? Because it doesn't seem to have a sustainable, it doesn't seem to have taken into account the sustainability of the financing.
Well, my candid assessment is it's actually sustainable and it's actually doable. Taking into cognizance the 5-pillar strategy, we have research. Research is evolving. The research doesn't just limit to the malaria treatment and all that. It limits to financing. Research in terms of finances, research in terms of, because we have partnership. Partnerships involve meaningful collaborations with governmental, non-governmental organizations and government at all levels. When we say government, now ministries are involved, ministries of health, and then NHIA are involved and all that. So it's not a one-man battle. Now, meaningful collaborations will come to pave way for partnerships that would further lead to sustainability of this. Because we also have policy and the policy and practice, in that wherever the policies, decisions are made, there is influence there. Decisions are made at all levels, so there is influence there. And then there is implementation of the solutions that are there. So I think when these 5 pillars are sustained, there should be a sustainability because it involves all the sectors, governmental, non-governmental, and then the government at all levels.
If this is foolproof, why do you have to worry about the inconsistency of a state government, for instance? Because you want a plan that these are politicians, they come and go, leaving such a vital strategy, to have them play with. Maybe this one comes and says, to hell with malaria and all of those things. Is it foolproof?
So that's what we say policy. It's not just a politician's, one politician's decision. Once you bring a meaningful discussion to the table, it can be implemented as a policy that would go beyond the administration. The administration may finish, yes, the politician may be out of office, but it has been a policy incorporated into the healthcare scheme, in that no matter the subsequent administration that would come, there could be modifications and all that, but it has been implemented, it has been put into the policy that this and this, in form of collaboration with malaria treatment, maybe subsidization of the anti-malarials, maybe free intermittent preventive therapy for pregnant women and all that. It has been put as a policy from the Ministry of Health at all levels and all that. Hospitals have implemented it, the CMDs have implemented it into the various hospitals. So even if you change the CMD, even if you change the local government chairman, even if you change the governor and all that, it has been implemented and it's put in place, and then people are seeing the impact of what is happening. So there could be modifications, but saying that it goes on with change of successful administrations, I don't think it's in line with what the aim of this 5-pillar strategy is.
Right.
It's aimed to go beyond political interference.
Thank you, Doctor. Let's get to Dr. Abikoye now. We're talking about how to eliminate malaria. I mean, I was a child when I started hearing jingles about the fight against malaria. I mean, it's been priority, I mean, for most governments and, of course, for organizations like yours, Malaria Consortium. But speak to us. Do you think that corruption and poor accountability is affecting the fight against malaria? He just said mosquito nets are free. I buy nets. I mean, from when I started having kids till today, I still buy nets. I've never gotten a free net. So I'm asking, what's stalling these processes? We're talking about lack of funding. The funds that are available, are they properly utilized? Are they going in the right channels?
All right, so I can rule out the fact that there are some systemic challenges which we are trying to address. But again, we should not be discouraged. For instance, there's what we call the National Malaria Indicator Survey. As at 2010, the MIS gave a prevalence, we found a prevalence of about 42%, 2010. 2021, MIS was conducted again, Malaria Indicator Survey, we had 22%. Another Malaria Indicator Survey was done last year, showing a national prevalence average of around 16%. So we are making some progress, even though slow. Some people might say it's slow, but we are making progress. We shouldn't be discouraged. We need to consolidate on our gains, on our efforts. You also mentioned the issue of IT and mosquito net not being given free. So it's not in all the states. For instance, we are planning for an ITN campaign sponsored, funded by one of our donors in FCT. Later this year. In the past 10 years, there has not been any mass campaign, ITN campaign in FCT, but the private sector is also there. Like she mentioned, you need to be informed. The critical private sector is also there. You can walk into pharmacies and procure nets, ITN nets, in the private sector, in our pharmacies, in our stores. So if the free ones are not available, in government facilities in some states, the state government funds procurement of ITN for pregnant women when they come for booking, even to encourage them to come for the antenatal. So every pregnant woman that comes to primary health center in some of those states gets an ITN free. That's to encourage other mothers to also come and register for the antenatal. Children getting measles vaccine at 9 months in some states, in primary health centers, gets this ITN free. That does two things: prevents the mother and the child, and also encourage other mothers to come to such facilities to complete their immunization.
I'm talking about poor accountability and corruption. Now we're talking about places where these nets are supposed to be free, but they are sold. What are you doing to check all of that, these interventions? What are you doing to monitor and ensure that, you know, it's reaching the right people at the pace that you want it to reach them, and free of cost?
All right, so like I said, there are systemic challenges, but as an organization, we work through the systems of government. We don't have the mandate to do some of these things, but we support. In every state, we have what we call the State Malaria Elimination Program that is seated within the State Ministry of Health. At the national level, we have the National Malaria Elimination Program, and of course, other partners like NAFDAC, Nigerian Police, the Civil Defense. So those systemic challenges exist, no doubt about it, but we are making gradual progress through collaboration, engagement, traditional rulers. So in states where we do mass distribution of nets, we work through existing systems, the World Development Committees, community leaders, religious leaders. But of course, like I said, there are systemic challenges, no doubt about that, but we are making gradual, steady progress in combating some of these challenges.
Right. Thank you, Dr. Abikoye. We've got some messages that have come in from our viewers, so perhaps we'll take them so that those that can respond to will quickly do. Now, let me begin with this one from Nandom Wiep in Jos. He asks, if a mosquito laying eggs on your wet clothes, if a mosquito is laying eggs on your wet clothes, can it transmit malaria when the larvae, the larva hatches on your skin? Do mosquitoes prefer fat or skinny people? Why is it that only the female Anopheles mosquitoes that spread malaria parasites and not the male? How do I identify an Anopheles mosquito? By the way, I'm also asking, why is it female? But it's okay, we'll get to that. That's one. And then this one from Mohammed Awal Musa Afamai, it's from Kanu, says, good morning, Nigeria. What local resources, such as youth groups or market associations, can be empowered to lead drainage and sanitation days without waiting for government intervention, which is key in eradicating malaria? And finally, from Ayebunam Anton in Delta, the insecticide-treated net is used only in bed. What happens when you are not in bed? Or does mosquito avoid biting people who are not in bed? All right. Perhaps Jennifer will lead the charge.
I think I'll start with the last one because it made me giggle. That's a very fair question. But mosquitoes actually bite more at night. So that's why we actually focus on
when you're immobile.
When you're immobile is when you don't notice. So because if you are awake and you're alert, if a mosquito lands on you right now, you're going to kill it.
You could be sitting out. in the open, maybe when there is no power supply.
But you're more likely, you're very correct, but you're more likely to not react by hitting it when you are asleep and not conscious. But they do bite you when you are awake. And that is why we said it's not just one thing. Nobody here has said that it's a cure-all. There are other interventions. We talked about larval source management. We talked about indoor residual spraying.
Even repellents.
Even mosquito repellents. There's a lot.
Protective
clothing. Yes. So there's a lot that can be done to ensure that you are. The beautiful thing is that people like that, I don't know, I can't remember who exactly asked that question, but people like that are asking the right questions.
Yeah.
They are trying to see how they can fully tap into the spectrum of protection, irrespective of what time of the day that it is.
So why female anopheles?
It's because it actually needs the blood. It's for the eggs to mature. That's all. You know, the same way you could see when you're pregnant, you crave. I mean, a pregnant woman needs more attention. You know, you did all the
someone
nutrition.
Someone once, you know, tried to liken it to witchcraft.
So there's part of the life cycle that happens within the body, and then within the body, I mean, inside we have the red blood cells, the liver, and all that.
That's for the parasite.
Yes, so
but for the mosquito, the reason why mosquito needs blood is to hatch its own egg, for the eggs to mature. The mosquito, in fact, the parasite kills more mosquitoes than human beings. Kills more mosquitoes than human beings. So the mosquito is not planning to do you favor. It can also bite a goat. It wants some red blood cells, wherever it can get blood. But it's just that human beings, you know, it's easier to buy human. You have more human beings than animals and so on and so forth. So the mosquitoes, they know where you stay, and then they know if you are asleep, you are asleep.
They know your name.
But the other person, mosquitoes laying eggs on somebody's
or
body.
wet clothes, I don't know.
no, that's not possible.
And they asked another, I said, do mosquitoes prefer skinny or fat people?
No, but again, I know we're all chuckling, but you know, we are encouraging people.
But is it true that some genotypes are more susceptible to coming down with malaria than others? Speak to us about that.
Well, okay, let me first talk about the skinny versus fat. No, the mosquitoes are opportunistic. They're going to get the blood where they get the blood, as Dr. Chibuzo said. So if you happen to be fat or skinny, that's your own morphological thing here. But we do have certain genotypes that are more susceptible.
Attractive.
Yes, that's I think that's O. Yes, O positive
Blood
people.
group, yes.
Okay, that's blood group, not genotype.
Yes, so the blood group. Yes,
Here we are.
people. Here we are. So we are the ones that actually are more susceptible.
Okay.
Yes, that's also one.
Okay, I have some messages. I'll read them, and then to respond to Victor's question about why female. Why female? Why?
Because they use that blood. The female are not for
You don't get his question. That's why female.
Judge you. Just we've established it.
Female. Anything female is special, and you have to be careful with them. That's just what it means. So even for a woman, you have to be careful. Else
for
you
the
get
propagation of their species. That's why.
All right. Let's read more comments that we have. This one says, malaria in Nigeria is really becoming a very serious challenge and needs an urgent attention to curb the menace. I have a question to your guest. What are the reasons that make some people to treat malaria at least twice or thrice a year? That's Alaji Gako in Karo site. Talking about people who treat malaria repeatedly.
Just as a habit.
In a year.
Some will say, have you treated malaria this year? You just go and treat.
And I was talking about parents who just give anti-malaria drugs to their kids once it's the beginning of a session. No, of a term. You know, they tell you to prevent malaria, for that term. And then the next time they do the same thing, whether or not the child is sick. Another one says, good morning, Nigeria. Yes, I agree with her that prevention is better than cheaper than cure. However, the question is whether the nets have reached every community. Was there any follow-up to ensure that the nets are actually being used? That's coming from Bashan from Gombe State. And another one says, what differentiates this strategy from previous efforts? And what of the issue of funding? Awal Musa from Kaduna. Another one says, good morning, guests in the studio. What is the government doing to reduce the stress patients using NHIA go through before they can access quality healthcare. My experience in a healthcare facility recently was very bad. That's coming from Femi in Abuja. I'm sure you want to respond, Dr. Bikoy.
Okay, so I think my colleague, who is the front line, should start, especially from the last question.
Coverage. So what we have in the NHIS is some of the facilities are stretched to their limit, right? And then these facilities are under the NHIA, but what the people see is what's happening in the facilities. They don't see what's happening between the people funding the NHIA. So talking about my facility now from the Federal Medical Center, Abuja, we have been stretched to the extent that over the last year we did not enroll anybody because we have stretched like almost 3 times.
Did you enroll anybody?
Yes, we have been stretched more than three times our capacity, but still trying as much as possible to accommodate people to give services and all that. So this is not in any way the fault of the healthcare facility. You understand? Because they depend on funding, they depend on allocation and all that from the NHIA. But still the NHIA...
It's the fault of who?
Well, the NHIA is still working. The population is massive. The population is massive. So the facilities are stretched. But still the NHIA is trying as much as possible to expand and to further fund the necessary healthcare centers.
Who provides the medication that you prescribe for patients under NHIA?
The medications are being provided by the NHIA because every hospital has a separate NHIA pharmacy and all that, and the medications are being provided by that. So various HMO would enroll their patients and all that. But as I said earlier,
So I asked that for a reason.
Okay.
Now, a doctor, you see a doctor, he prescribes, he gives you a prescription. If you're NHIA, you go to the pharmacy and they tell you, well, what the doctor has prescribed, we don't have. They have something less most times, right? You go back to the doctor says, this is what I've prescribed for you, not what is in the NHIA pharmacy. So is there a likelihood that what is available in NHIA pharmacies are not standard prescriptions for certain ailments?
No, this one I can categorically say no. Like talking about that from my facility, there are differences in different health centers. From my facility where I work, Federal Medical Center, Abuja, we have the same medications if you go to the NHIA pharmacy because we use electronic medical record in the first place. So there won't be that this brand of medication is different from this brand of medication. The same medication, maybe a brand of amoxiclav we are using, let's say maybe I'm using Augmentin or anything. The same brand is the same from the NHIA pharmacy. The same brand for the adult pharmacy, the same brand for the private.
There's disparity in the facility that I use. Exactly. I can say that clearly.
Yes. So you mean that is individualized to, yes, that's individualized to different facilities.
And sometimes it could be available for the hospital, but not available for NHIA. This, I have experienced all of this.
Yes, so as I said earlier, it's individualized to different facilities, but from my own facility is the same medication. If you go to the NHIA pharmacy, even the antibiotics and all that, they are the same. I think the stocking and everything is the same. So we don't witness that disparity where I work. I think maybe that's why we have the high.
What was changed?
There are different classes of
we'll come back. I just wanted him to hold this question because we are going on break. But what has to change for NHIA to work for Nigerians? It's something I want you to chew on, but you'll respond after this break. Please do stay with us. The conversation continues. All right, thank you very much for staying with us. Of course, a very interesting conversation we've been having, discussing the 2025 to 2028 malaria strategy. And I left Dr. Sani Bala a question, but I have 2 messages that have come in. So I'll take the messages while having an eye on the question I left with you. Let's just see what they are. Now, this one is from Ese Ogene Adioma More, a gift in Delta State. I love your discussion on 2025 to 2028 malaria elimination strategy. I would really love it to be a success story, especially here in Delta State. I am a community health worker. Okay, thank you. And then this one reads, good morning, Nigeria. My name is Ose. I was ill and went to a health center in Lagos. I did malaria test, and it was RDT negative. But I insisted on microscopy because I was very sure of the symptoms I had. The microscopy result was 1+. I asked why. The nurse told me that the new practice now is they don't tell patients they have malaria. I was really shocked and confused. Please, can you throw more light on this? I think both will go for you.
Okay. So for the rapid diagnostic test, from the name, it's rapid, so it uses some antigens for a specific type of plasmodium, because we have 4 common plasmodium. We have many, but the 4 common, we have Plasmodium malariae, we have Plasmodium vivax, we have Plasmodium ovale, and then we have Plasmodium falciparum. So the antigen that is rapidly detected is mostly for Plasmodium falciparum. So sometimes it gives a false negative, in that other species of malaria-causing parasites would be the ones, the offending organisms there, which would not be picked from the rapid diagnostic test. So that's why, as doctor said, the gold standard is microscopy, where you check under the microscope to see the species of the plasmodium, to see the burden, the number of the plasmodium, so that it will inform your decision. So this disparity is not uncommon in clinical practice, in that it has been missed the other species of malaria, mode of testing. But what they, even though I'm not sure a nurse would say that, but what the supposed nurse told her is far from what is obtainable and it's wrong per se, because a patient has a right to his test result. A patient is part and parcel of his treatment, so she should have the right for explanation of the disparity, and then educate her, because each session with a patient is a medium for educating the patient. So they should have educated her on the difference between the rapid diagnostic test and then the microscopy and then the modality of treatment.
All right, let's read some more messages. This one says, good morning to the presenters and the guests. The doctors have done justice to the topic of discussion, malaria elimination strategy. I want to advise that we invest in building the character of people towards the topic. Many people abuse some of the strategies put in place for elimination of malaria. Example, the use of treated nets. If you go around you would see that these nets are used on farms for protecting crops from mosquito instead of human beings. I mean, some use it for fishing, by the way. Such people should be punished. And that's coming from Mando Jefta Yaks in Jos. Another one says, Dr. Yakubu Forsum in Shendam, local government area, Plateau State of Nigeria. I wish to appreciate the government and partners in the effort to eliminate malaria. Honestly, the government and partners are doing well, most especially Malaria Consortium and the Presidential Malaria Initiative. Kudos to you all. Another one says, good morning, discussants and Nigerians from Umwefuru High Center in Abakaliki. I commend the federal government on her free malaria treatment, especially for children, as is provided in primary health centers. However, at some of the centers, the workers collect money for the tests, claiming the test kits are not provided by the government. Please look into that. And finally, another one says, how can one eliminate malaria by using the net? I think we should focus more on our environment before thinking of eliminating malaria. That's coming from Jacob Dapak from Jos. And talking about this environmental issue, I hear that there's a community, or rather in places like Kebbi or so, rice farms, you know, these mosquitoes, you know, breed and all of that. So, I mean, this issue about the environment is also a critical point. So, who wants to take a shot?
So we are currently engaging with Kebbi State, with the farmers and everybody. And as things unfold, more will happen.
Could that be why we use nets in the farms? So maybe
the mosquitoes don't bite your rice. You understand? It's just that there are other weevils and other things that attack their rice. They prefer the harvest to being healthy. You know, and those are the things we still need everybody to help us to educate the people. That yes, we got it free. Somebody paid for it. And there are some people that would have preferred it and they would have used it, but you are giving the priority, because if you see the people using these things, there are still people in the rural areas. Can't see anybody in Maitama using mosquito net on his flower, you know, or his farm. No, it's still people there. So we need the help, the support of the media and everybody. You know, I like some of the things.
But what's your strategy for creating awareness?
Okay.
Because
there's social behavior. Okay, I will leave hand over to Dr. Tayo.
Like we've been saying, behavioral change is a continuous thing. You need to continue to engage with people, for them, especially adults. Changing attitude, changing habits can be difficult. So it's a continuous engagement. We need to keep talking to our people for them to have the right attitude. So when we do mosquito net campaigns, I-10 campaigns as it is in some states, we have what we call SBC, social and behavioral change communication strategy, before the campaigns, when the nets are being given, and after the campaigns. And we walk through community leaders, like I mentioned earlier. We work with Market Women Association, we work with World Development Committee, we work with traditional institutions. But again, like I said, it's a continuous thing. We need to keep at it. We need everybody. Again, one of our strategic pillars speaks to partnership to drive systemic change. We need everybody. We need the media. We need the teachers to tell the pupils in the school, to even educate their parents when they get home on the right use of some of these nets. So it's a joint, it's a collaborative effort for us to get our desired result. We need everybody. We need all hands on deck.
Speak about the net specifically.
Sorry, ma'am. I was very happy with a comment made by somebody from Kano. He said, we clear all these drainages. We make sure there are no stagnant water while waiting for government. That's a good thing. That means it's reaching some people. So we thank whoever is making it reach these people, and we're asking for more.
Now, Dr. Chukwumeri Jade, speak about the nets, how to use the nets. I mean, this is a medium for educating people now. How to use the nets, can it be washed, what to do when it's torn, in case you don't have a replacement. Speak about all of that.
Okay, thank you very much. You actually brought into the last, I think your question also can be layered with the last question, where someone said we shouldn't just focus on nets. And I want to assure the person that the National Malaria Strategic Plan is not just, as we keep mentioning, they are strategic pillars. We're not just looking at prevention, we're looking at proper diagnostics, making sure that there's the ability to test properly, making sure that when you test positive, you also receive adequate treatment. We are looking at health education, SPCC, different areas, just to make sure it's not a one-size-fits-all approach. So specifically to the insecticide-treated nets, these nets have a lifespan. So they will not, the insecticide that has been impregnated into the net will not stay active all through. So it is important for people to know, please, you can wash them. Yeah. That's another thing. In fact, let me give a personal anecdote. When my first son entered secondary school, a lot of children, this was during COVID, a lot of children came down with runny noses, red eyes, boarding school, and everybody was like, oh, it's probably COVID. But that was the nets. Because nobody had taught these children that you should expose these nets. So when you get them, you should sun it for a period of time before you use them. You don't just put them up. Again, you should also put them up properly. So identify, adequate. Some people put poles over the beds. Some people maybe hang it from the roof, because if you notice, those nets usually have cords or strings that are attached to them. And you also make sure that you tuck them under the bed so that it's,
to minimize contact.
Exactly, and also, you don't have any outlets for the mosquitoes to come in. You asked about fixing the nets. Yes, you can. These nets are made from cloth, so if they tear, you can easily sew them, right? And we do the recommendation for universal net usage is every 3 years. So we actually encourage mass distribution of nets every 3 years, because that's the lifespan. So we aim to make sure that when it is done well, so because I don't want the next question to be, this is not what is always done. The ideal is that when these nets are shared, they are shared to all the households that need them, and they are used. So it's not just about distributing the nets, it's also about net utilization. One of the things that and someone had asked, how do we ensure that they are used? We have surveys at the end of our net distribution campaigns that assess the utilization of these nets. So one of the things that you can ensure is that when your children are about to go to bed, even yourself, I mean, I speak about Dr. Chibuzo, I know for a fact this is one adult that always sleeps under the net. I do that. I'm also, I've learned it from him. Yes, it's very commendable.
It makes you creep in and creep out all the time. That's some trouble.
But when we layer that against spending
your health,
you have to take ownership of your health. So it's just important for people to know that they can wash these nets, they can maintain.
Since you say it expires,
yeah,
I'm just thinking, during you talked about COVID. I'm sure you saw how foodstuff that was meant to be distributed during COVID was distributed in, I don't want to say the time. Okay. So sometimes, maybe a particular net produced in 2020, right? That would have been distributed in 2020. can find its way into a warehouse and come out in 2026. Is this still effective?
Okay, so when she says expire, so the fiber of the net, maybe polyester, is impregnated with some chemicals, insecticide. So the lifespan of the chemical that the fiber of the net is impregnated with is the one that has the lifespan. So the net does two things, okay? It serves as a barrier, contact between the vector, which is the mosquito, and the person sitting inside sleeping inside the net. So when you notice that mosquitoes or even other insects perches on the net, it kills them because of the insecticide. So that insecticide can last for up to 3 years.
So
but the barrier...
The question is, if that net was not used after 3 years
or distributed,
yes, that's usually the case in you know, is that still effective? That's insecticide.
Okay.
Yes.
So the idea is this: the ones that we deploy programmatically, we bring them in. They are not expired, and we give them out as much as possible. Something we try to do is to open the net and from the nylon from the polythene and hand it over to the mothers, so that they will be. I don't want to use the word forced to use it, but until you open the nylon, the expiration doesn't start counting.
Okay.
Yeah.
So it's until you unpack.
Expose it.
Okay.
Now, Nigeria recently introduced the malaria vaccine. How significant is this development in all of these? Dr. Jennifer, or you think someone else should get it?
No, I mean, everybody else can add. There's no, everybody has their ideas, but you're very correct. This is a massive innovation, especially when we look at the fact that, as we've mentioned, we've all iterated, malaria burden is highest in children under the age of 5. So what this does is that it complements the other strategies that we have already available when it comes to malaria prevention. And as Dr. Chibuzo had mentioned, we've gone from not having these vaccines readily available to having them really it's really available right now, and it's about funding to source them and make sure that it reaches every child that needs them.
About $3.90 now.
Yeah. Yeah.
Each.
Yeah.
Yeah.
90 cents.
And also ensuring, because it's a vaccine, so just to point this out, it's not just about getting the first vaccine, it's to ensure you also get the full follow-up doses. Because this is one of the... so the first, it's the booster dose. It's 3, and then there's a booster dose. So the thing about it is that there's a misconception that
COVID. Just like COVID, yeah, because I remember the booster language.
Yes. Well, a lot of vaccines have booster doses, yes. So one of the misconceptions that we have, or that caregivers tend to have, is, oh, my child got it and my child is fine and the child is forever protected. No, it will actually reduce the frequency of malaria. And then we also encourage, you don't stop sleeping under nets because your child has gotten the malaria vaccine. If your state is one of the states that also implements SMC, seasonal malaria prevention, also utilize it. These things all accumulate in helping prevent malaria.
All right, we need to go. Our time is almost up, but I'd like to come to Dr. Abike, because you are the one who kept talking about research and research. I'm thinking that if we're doing research in terms of finding local solutions to this problem, don't you think we'd be far ahead instead of depending on Western medicine in dealing with this? Because I know a lot of people will tell you, well, if you do the back of this, the back of that, so why don't we focus on such research, just that so that everybody can easily access medicines, you know, that can take care of this?
Well, but I'm not an authority in that area, but I know there are efforts of the federal government. There's the Federal College of Alternative Medicine under the Federal Ministry of Health, and I know there are a lot of things happening. There's also these institutes, pharmaceutical institutes, NIPRIT, somewhere in Idu, National Institute of Pharmaceutical Research. They are looking at local solutions. But within this malaria space, something I can speak to, the sector-wide approach, we have a very brilliant, wonderful Minister of Health currently. So there's this presidential initiative on unlocking health sector value chain. So right now we are looking at local manufacturers of these anti-malarials to reduce the cost on importation, freight, custom clearing, to get them WHO certified. A lot of things are happening. Give them some waivers, some tax relief to ensure that some of these anti-malarials that we're importing are being manufactured locally. Even insecticide treated nets we import from China, from India, from Vietnam. But I'm glad to let us know that through this presidential value chain in unlocking healthcare sector value chain, this year ITNs will be produced in Nigeria. Over 60 million will be produced in country, WHO standard, through federal government initiative. So a lot of things are happening. We might not be seeing the immediate result, but I think if we sustain it, if we can keep the gains and we jointly work collaboratively, work towards our vision of a malaria-free Nigeria, it's not going to be an easy work, but I can see that we can get there. And we need everybody. We need that robust partnership with all hands on deck.
All right. And Dr. Ogwoma, how critical are community-based interventions if you are looking at achieving, the elimination targets?
Yeah, that's where the people are. More than 75% of our people are at the community level. So if we do not go where the need is most, how are we going to achieve anything? So it's very important, all those mass community, while building the health system, strengthening them, we'll see some of these interventionists, even though we're integrating and co-implementing, to make sure that the people that are at the community level are reached. And that's the reason why most of these mass campaigns continue. You know what to do. I mean, you can decide to spend the next 3 hours at your physician's clinic. The person that is at the hard to reach or complex operational environment will not be able to do that. It doesn't have the access, it doesn't have the resources. So the community is where we must focus, we must, tackle equity issues and scale up, universal health coverage.
All right, Dr. Umar, your final words as we... Dr. Bala, I apologize. Dr. Ahmed Sani Bala, your final words as we round off. What would you really want Nigerians to do in the fight against malaria?
Okay, what I would really want fellow Nigerians to do is in terms of appropriate and timely health-seeking behavior. Not every fever, I reiterate, not every fever is malaria. Not every joint ache is malaria. Not every headache is malaria. So once you have a fever that is persisting, you present to the nearest hospital where you get tested, appropriate investigation done before commencement of treatment. And then also, when you have complications, you come to the hospital, so that because severe malaria, it has high mortality rates, especially in children. Cerebral malaria, you see it with complications and all that. So once you start having protracted fever and all that, present to the hospital so that treatment will be initiated after appropriate investigation.
All right, thank you. Dr. Chukwumeri J, 30 seconds, your final words on this topic.
Okay, so I would like everybody to know that malaria is preventable, malaria is treatable, and it is increasingly controllable. But this can only be done when we ensure that those proven interventions that have been put in place are equitably distributed. We reach every child, we reach every pregnant woman, we reach all vulnerable communities.
Thank you so much. It's been a pleasure talking with you doctors in the studio. Dr. Chibuzo Ogwoma, Program Director, Malaria Consortium. Thank you so much for being our guest. Dr. Ahmed Sani Bala, Department of Family Medicine, Federal Medical Center. Thank you so much. CEO, Vital and Medical Foundation. Indeed a pleasure. Thank you, Doctor. Dr. Jennifer Chukwumeri, Technical Specialist, Malaria Consortium. Thank you. Well done. Keep up the good work. Dr. Olatayo Abikoye, Country Program Director, Malaria Consortium. Thank you. I hope to have you. I hope we can have you guys, come talk to us some more about the progress that you have made. I'm sure in the coming months, and where you have challenges and what it is we can do to scale up all of this. Thank you. Well done. We hope we win the fight. Mosquitoes.
You haven't thanked me. You haven't thanked me for being beside you.
And doing what for me? Please. All right, it's time to wrap up. Victor owes me quite a lot. I hope he delivers this weekend. I'm Ian Ray John, Level Locked on the NTA.
All right, and I'm Victor, as well. Thank God it's Friday.